is Dr. Fidarova from Moscow, Russian Federation. Thank you very much on the PNH clone size at the start of aplastic anemia are closely associated with transformation in clinical significant PNH.
Thank you. Dear colleagues, thank you for this opportunity to speak in front of you today. Our report is about the correlation between PNH clone size at the start of aplastic anemia and its transformation to clinically significant PNH. My name is Залина Фидарова. I'm here on behalf of National Medical Center of Hematology in Moscow. I am hematologist. I have nothing to declare. So, PNH clone is known, escapes immune attack and are closely associated with bone marrow failure syndromes. Current immunosuppressive therapy proved to be effective in above 80% of patients with aplastic anemia. It's worth noting, though, PNH clone increases and become clinically significant when the remission of aplastic anemia was achieved. But it's still not determined if PNH clone size on the onset of aplastic anemia affects the rate of progression to clinically significant PNH, and if signs of intravascular hemolysis and the onset of aplastic anemia affects the rate of progression to clinically significant PNH. That's why the purpose of our study is to find out which groups of aplastic anemia patients are at high risk of progression to clinically significant PNH. We evaluated PNH clone in 138 treatment-naive patients with aplastic anemia between May of 2012 to October of 2022, namely 74 males and 64 females with median age 26 years old. PNH clone assessed by flow cytometry protocols, it based on ICCS, ESCCA, PNH consensus guidelines, and you can see the distribution of aplastic anemia patients according to the PNH clone size, and only 23 of patients had PNH clone greater than 10%. Immunosuppressive therapy predominantly consisted of horse ATG with cyclosporine treatment, and only 9 patients received monocyclosporine with L-trombopag in some cases. Cyclosporine treatment lasted for at least 1 year after remission of aplastic anemia was achieved. And the 10 years overall survival is 88%. And when we, and it's worth noting, though, when the patients were divided into groups depending on the presence of PNH clone, no significance of clinically significant PNH development is 16.5%, and 10-year probability is 18.3%. The rate of progression to clinically significant PNH was significantly higher in aplastic anemia patients with PNH clone size greater than 10%. And the median time to PNH progression with PNH clone greater than 10% is 5 years. Further, we decided to test whether the presence of hemolysis at the disease onset has an impact on the progression to clinically significant PNH. PNH clone greater than 10% in association with high LDH activity was referred to as PNH syndrome at the disease onset. We had 32 patients with aplastic anemia and PNH clone greater than 10%. Among them, there were 62.5 patients with PNH syndrome, and only half of patients in both groups were progression to clinically significant PNH. High LDH activity in treatment-naive aplastic anemia patients with PNH clone greater than 10% was not significant for progression into hemolytic PNH. And we can see that the median time to PNH progression was lower in patients without hemolysis at the disease onset, 48 months versus 60 months. When we compared groups of patients with and without PNH clone, no significant differences between PNH clone size we observed, and the risks of PNH complications were also comparable. However, it draws our attention the fact that all clonal events are concentrated in the group without PNH syndrome. But this is the topic of future research. In conclusion, I'd like to say that the treatment-naive aplastic anemia patients with PNH clone greater than 10% are more likely to develop clinically significant PNH after hematopoiesis recovery. Results of our study indicate that half of aplastic patients with PNH clone greater than 10% develop clinically significant PNH in 5 years. I appreciate the help of our colleagues and supervisors in National Medical Research Center for Hematology. You can see the small part of them, our team on the current slide, and thank you for your attention.
Thank you very much. Any question from the audience? Okay. If not, thank you so much.